Good morning and welcome to Medicine Grand Rounds. It's really my pleasure to provide just a brief introduction to today's program. This is a special day. Annually, there's a Rankin Scattrud lectureship that's going to be explained first by Dr. Jerry Dempsey, who's a professor emeritus in population health sciences and physiology. And Dr. Dempsey is going to be introducing our Grand Round speaker. Please join me in welcoming Dr. Dempsey.
Good morning. This occasion, every year we celebrate the contributions of Dr. Rankin and Dr. Scattrud. And they, first thing we do every year is to award travel awards in their name to students in population health science and in the pulmonary division research. And we have two of the three awardees here this year. Shoshana and Kumar, could you please stand and be recognized? Congratulations. Let me tell you something about these two people. John Rankin was a native of Glasgow, Scotland, and while a resident there, he developed a prognostic scale for stroke called the Glasgow scale, sometimes called the Rankin scale. So as a young man, he was already a pretty famous researcher, still used today. At the UW, he served as chief of the pulmonary division in the Department of Medicine for many years, and for 13 years was chair of the Department of Preventive Medicine. It was as chair of the Department of Preventive Medicine, he really built that department into what he described as a mini school of public health. And it was a template for how it exists today and thrives today with that kind of model. Dr. Rankin conducted pioneering research in lung disease and specifically in farmers' lung disease and was very important to the state. Jim Scattrud is a native of Wisconsin from Manitowoc. He was a UW graduate. In fact, I taught Jim in medical school the first year I was an assistant professor. He was chief of the pulmonary division for over 20 years. And he pioneered research into sleep apnea at the UW, beginning with very basic physiologic studies on the causes of central apnea in sleep, and those findings still hold today. And he was instrumental in the contribution to the Wisconsin sleep cohort, the epidemiology of sleep apnea, which continues on today. So both Dr. Rankin and Dr. Scattrud were excellent physician scientists. But what a lot of us remember them more for was their mentorship. They treated their young colleagues, me included, and many here in this room, with great respect, and they were exceptional listeners. And so their legacy lives on in many, many areas at the UW. Jim Scattrud's very best student was Safwan Badr. And he's our Rankin Scattrud professor this year. Welcome, Safwan. Of Nizar Jarjuers, and they both came together to do their residency at Cook County. Then he came to the UW in 1986 and was here as a fellow and a junior and a tenured faculty member. Safwan had a major contribution to sleep apnea research here at the UW. He was a joy to work with. He became an independent researcher very early in his career here. Since he left Madison, he's been at Wayne State University, where he's the chief of the Pulmonary and Sleep Division, and he's contributed substantially to research in the field of sleep apnea and to mentoring people as well. His research on the gender effects and the pathogenesis of sleep apnea, the effects more recently of spinal cord injury, and how central and obstructive apneas relate to one another. It's really good stuff and very important to the field. He's been recognized by his peers and elected to leadership positions in the Thoracic Society, the Sleep Society, and the American Academy of Sleep Medicine. Safwan's going to talk to us this morning about what he knows a lot about sleep apnea. Thanks, Safwan.
Thank you, Jerry. I'm truly honored to be here today. I probably owe me standing here to two people, to Jerry Dempsey and Jim Scattruth, for their mentorship. So this is actually a great honor. And for me, this is also home. And I'm grateful and thankful for all the hospitality that Jerry and Nizar and the two groups, the Pulmonary Division and the Rankin Lab, have shown me. Thank you. So what I'm going to talk about today is sleep apnea in the broadest term. And the focus of this will be relevant to the daily practice of medicine. We all know about the role of gender, the role of obesity, but there is a whole lot in this that we actually don't know. But I'm going to start by talking about sleep in general and sleep deficiency. And this conversation has emerged in the past 10 or 15 years, that not just broken sleep with sleep apnea, but sleep as an entity is critical to life. Talk about sleep disorder breathing and some areas we need to think about in our daily practice, and then outline a brief diagnostic and management approach. What does sleep do? That's the question I always get from everyone. What does sleep do? Well, we don't really know, but this is a famous line in the sleep field by Alan Rechtschaffen, who's one of the two co-authors of the sleep staging that we all use, the R and K. And he said, if sleep does not serve an absolutely vital function, then it's the biggest mistake the evolutionary process ever made. So now we're talking about sleep. By show of hands, how many here get 7 hours or more of sleep per night? That is actually a minority. Okay? How many get less than 6 hours? That is an equal minority, and that is part of what we're actually seeing. Well, we really still don't know what sleep does. But now there is emerging literature to say that, guess what? There is a measurable biological function. And this is just an example from it's a murine model. And on the left, you will see that there is the red part is actually during sleep. And on the right is during wakefulness. The CSF influx during sleep is higher. So the idea is that during wakefulness, we accumulate amyloid. These are the metabolic waste product. And these are toxic to the brain. And during sleep, these lymphatics, and they're calling them glymphatics, open up and allow the brain to drain its metabolic waste. So the term that's been coined is the garbage truck of the brain, clearing the brain of all what accumulates. Now, where else have we heard about amyloid? Yes, Alzheimer's disease. So now there's some conversation starting. Is there a relationship between sleep deficiency and neurodegenerative disease and Alzheimer's disease? Again, this is a huge leap at this point, but now we have some clearly measurable biological function. So instead of just talking about insufficient sleep, we talk about sleep deficiency as a broader umbrella. And sleep deficiency encompasses insufficient sleep, poor sleep quality, fragmented sleep from sleep apnea, periodic leg movements during sleep, misaligned sleep, circadian rhythm, shift work, jet lag, or primary sleep disorders. And here we're talking about something like narcolepsy. Now, our current standard for sleep, we can blame this gentleman, okay? Our current culture talks about sleep as a waste of time, burning the midnight oil. Oh, I stayed up all night. So, this was the beginning of the dark ages of sleep health. Now we can have the lights back on. Okay. Now we can see the light and know that actually sleep deficiency, insufficient sleep, sleep curtailment is not a virtue, is not of value. In fact, it affects our performance, it makes us grumpy, accident prone, and it contributes to the obesity epidemic. Now, this is a change, and look at simply where I circled in men and women, and you can see from 1985 till 2004 that the percentage of adults who are reporting less than 6 hours per night has increased substantially. So now we actually do have a national epidemic of insufficient sleep. It's 50 to 70 million according to the Institute of Medicine's survey in 2006. That number is probably a little higher. So we may be talking about 1/5 to 1/4 of the US population aren't getting enough sleep, insufficient sleep. And the other group that is really suffering disproportionately are high school students. High school adolescents, 70%. Now add to this that high school adolescents really are phase delayed. They want to go to bed later and wake up later. And what time do high school starts? Very early. And what do they often have first hour? Math. And that highlights part of the problem that we have. And there is a move nationally, a movement afoot of changing school start time for high schoolers to begin a little bit later. Now, this is not just feeling fatigue. Sleep curtailment is actually pro-inflammatory. So when you don't get enough sleep, many times we feel a little achy, a little tired, and actually this is an inflammatory state. And if you look at, you can clearly see that there is the IL-6 level is higher under sleep restriction than under usual conditions. And there are, I can show you tens of slides of different markers of inflammation that all show exactly the same thing. Now, many of us sometimes get a poor night's sleep, and we don't sleep at all, or we can't sleep, or traveling. After a night when you're unable to fall asleep, how many of you wake up in the morning and say, boy, I'm really craving salad? None. Okay? Instead, we crave donuts, muffins, carbs. Okay? We actually crave carbohydrates after sleep restriction. Okay? To make matters worse, our ghrelin and leptin are actually inverted. So our ghrelin is higher and our leptin is lower, which means we are hungrier after sleep deprivation. No wonder then, and this is from the Wisconsin sleep cohort study, that individuals who have low hours of sleep, 6 hours or less, actually have a higher BMI. So clearly there is an association between sleep restriction and weight. Now, could there be a relationship between our current obesity epidemic and our sleep deficiency epidemic? I wonder. Now, the ultimate outcome is mortality. And this is a large number, 636,000 men, 480,000 women in the cancer prevention study. So this is a large number. And there's something interesting. You see the U-shape. And the U-shape tells us here, so those who are insufficient sleep, low sleep, have a 1.2 to 1.4 odds of mortality than those who are getting 7 or 8 hours of sleep. Now, the part that's been peculiar to researchers is this part. Is long sleep really bad? If somebody sleeps 9 hours every night and feel fine, should we tell them to cut it down? Nobody knows, but probably not. For the most part, this is self-report. And at least the common wisdom, or lack thereof, is that this is time in bed for people who have more chronic conditions, rather than actually insufficient sleep. So for the most part, everyone agrees on this part. We don't really know how to interpret this part. So in the most recent ASM guidelines or recommendations on sleep, we really didn't touch on this one because we don't have enough data. Now, sleep deprivation has major consequences. Car accidents. Okay? 250,000 US drivers fall asleep at the wheel daily. Okay? We can just scan to the bottom of this. A fatality every 70 minutes. So from the time I started this talk to the time I walk out of here, which is about 70 minutes, one person in the US would be dead in a car accident. That's a number to remember. And a lot of these are all related to sleepiness, to falling asleep behind the wheel. Many of our big industrial accidents, catastrophic industrial accidents that had tremendous societal and human cost, environmental cost, human cost, were clearly linked to sleep deprivation. 3 Mile Island, the Exxon Valdez, Chernobyl, and this one. Who here remembers, obviously people who were born after 1985 will not remember, who here remembers where they were standing or sitting when the shuttle disaster happened? Okay, we all know exactly where we were at that moment. Well, this is what the Presidential Commission on the Accident Report said years later. The willingness of NASA employees in general to work excessive hours, while admirable, I love this, while admirable, raises serious questions when jeopardizes job performance, particularly when critical decisions are at stake. So even this one has a link to sleep deprivation. So we're not doing anyone a favor by staying up all night. I hope I convince you that sleep is important and that insufficient sleep is not a good thing for you, and it's actually something we can deal with and we can manage. Now I'm going to switch gears to the respiratory system. Here I'm just saying how cuddly and nice sleep is. But then, what about the respiratory system, which is where I came into the sleep field from? Is sleep cuddly or grisly? And the question is, like a lot of things, it depends. But I'm going to show you some data. It's actually data I obtained while I was here, and some of it were from my other colleague, Kathy Hinkey, is that to some extent, sleep for the respiratory system is a challenge. So this is fiber optic image of the upper airway, retropalatal airway. We had a scope placed. We can see the soft palate. And this is the outline during inspiration and expiration. This is a young, healthy woman. When she fell asleep, look what happened to her upper airway. The airway narrowed. And that actually happens in each and every one of us. The resistance to flow increases. Actually, if your neighbor falls asleep because my talk is boring, you will know that because you will hear their breathing, their higher turbulence. It's now rhythmic and louder. So we decided to actually investigate this systematically. Look what happened to the cross-sectional upper airway, retropalatal, and this is work with James Rowley and I in Detroit. And this is the cross-sectional area fiber optically during wakefulness, non-REM, tonic REM, and phasic REM. Clearly there is a decrease. These are normal, healthy individuals. They decrease the cross-sectional area of their upper airway just by falling asleep. So this is stable N2 sleep. Snoring. This is how I see a lot of my patients. They're dragged by their bed partners because of their snoring. So snoring is when the airway narrows a little bit more, narrows enough that the turbulence now becomes loud. The soft palate starts fluttering, and we will hear that beautiful noise we call snoring. And this is what happened to the mechanics of the airway. So if you look at the top panel, EEG, flow below it, tidal volume, then supraglottic pressure, which is the pressure, the negative pressure you generate to breathe, and this is the end-tidal CO2, a surrogate for arterial CO2. And look what happened from wakefulness to sleep. The tidal volume dropped, the flow decreased, there is more work. Look at the amount of negative pressure. You generating more negative pressure, but you're getting less flow. That is a challenge to the respiratory system. And the carbon monoxide increased. In this slide, this is work from Kathy Hinkey when she was here in Wisconsin. And here I'm showing you the diaphragmatic EMG, the scalene, and the abdominal. Look at the activity. This is the activity in the baseline. This is the activity of the diaphragm in N3, much higher. Look at the abdominal muscles. I'm drawing a line here with the CO2. Look where the CO2 was. CO2 now is higher. So during sleep, we generate more effort, we get less flow, our CO2 is higher. This is a challenge. Add some body weight to this picture and you have a worse issue. And that is the pathway that we go from normal airway to a partially closed airway in snorers to a fully closed airway in patients with obstructive sleep apnea. It's a continuum of narrowing and collapsibility. So what are the symptoms? How do we evaluate? Well, snoring is pretty much the most dominant symptom. Excessive sleepiness, witnessed apnea, multiple nocturnal arousals, headache, and reflux is one of the common symptoms that we often miss. This is a typical polygraph from a polysomnogram. This is the flow, and you can see there is absence of flow where the arrow is, and with persistent activity. So that's a classic obstructive apnea. This is part of what a polysomnogram, where we actually obtain all the signals, including EEG. Now, many patients are studied with only the respiratory signals at home. And if you take this in a compressed segment, we call it a hypnogram. On the left side, you see these are all drops in saturation from the respiratory events. We applied nasal CPAP, and this is what happened. We stabilized respiration. So how common is the disease? Well, in 1993, the Wisconsin Sleep Cohort study was the first of its kind to study community. So these are 600 community dwellers, state employees residing in Dane County, and some were snorers, some were not snorers, and had full-time in-lab polysomnography. At that time, this idea was revolutionary, that you are going to study individuals, all of them, all 1,000 of them, actually in the sleep laboratory. So this is redrawn from the original paper. If you look at sleep apnea as 5 events per hour of sleep, and that's the number we use. We count the apneas and the hypopneas, and we average them per hour of sleep. And that number, you will see that 24% of the men and 9% of the women met the minimum diagnostic criteria. That's a pretty high number. This is not a disease yet. This is just a laboratory finding. And if you look at snoring men, about 33%. So if a man, in middle-aged man, says they snore regularly, 1 out of 3 have sleep apnea. No further questions asked. Pretty high number. But that means 2 out of 3 don't. So let's not make assumptions. In snoring women, it's about 20%. So that's a high prevalence of disease. Now, when that was converted into a syndrome, which is that finding plus daytime sleepiness, 2% of the women and 4% of the men had the disease. So now that is the syndrome of obstructive sleep apnea. A few years later, Hershey, Pennsylvania, this is Bixler, and they studied 1,700 or so community dwellers and found similar numbers. So if you look at, this is what this syndrome is, somewhere between 2 to 4%. So these numbers are fairly comparable in two areas in the United States. So if we talk about the different risk factors and see how these things may have changed, obesity has always been number 1. Reflux, diabetes, and chronic kidney disease are the others. So let's talk a little bit about obesity. So when the Wisconsin Sleep Cohort study was published, this was the map of obesity in the U.S. Okay? Wisconsin and Michigan were both blue. Not necessarily blue states, but just blue, meaning 15 to 19%, okay, of obesity. Fast forward to 1999, when the Bixler study was published. You guys are still blue, but my lovely state of Michigan turned into the above 20%. Fast forward to 2010, and now everybody is above 25%, okay? And Michigan is above 30% obesity. What does this do to the prevalence that we've estimated? Well, it's interesting that in 1995, Time magazine had this cover, Girth of a Nation. Yeltsin, anybody remembers that character, was still around. So how does obesity affect things? Well, this is also from the Wisconsin Sleep Cohort study. When you gain weight, it gets worse. When you lose weight, it gets better, probably a little bit less. So this is the interesting, I'm going to take you with a number. So someone whose weight is 150 pounds, and over a 4-year period became 166 pounds, which meaning they went here, slightly over 10%. This person had AHI of 1. Now this person is going to have AHI of 6. So 10% of body weight, you will go from normal to actually meeting the minimum diagnostic criteria. Unfortunately, the reverse isn't as easy. You actually recover less when you lose weight because probably the disease has already been established. Other things may persist. So what many bariatric surgeons tell their patients that I will cure your sleep apnea, they're probably incorrect by saying so. This is the other large study, which is the Steepheart Health study, where they studied 6,000. They studied them with Polysomnogram at home, and there was a difference between men and women in the response to weight changes. So it clearly looks that the men especially, the increase, were a lot more susceptible to changes, to increasing weight. So Paul Papard, here at the University of Wisconsin, re-looked at the data and said, okay, let's re-estimate the numbers based on the changes in the obesity epidemic. And he estimated that between 1988 and 1994, that the prevalence was about 26%. And that in 2010, it's somewhere around 34%. And for women, went up from 13 to 17. And when you look at the symptoms, and his numbers with symptoms look a little bit higher, went from about 10, 11% to 14%. So 14% of the men have sleep disorder breathing with symptoms. That's real. That's significant. And about 5% of the women. And again, that corroborates the other slide I showed you, which is men seem to be more vulnerable to changes in body weight. Another association with sleep disorder breathing is reflux. And we tend to see this a lot, and many patients with sleep apnea suffer from this condition. And actually, it's one of the signs I ask them when I treat them. Because if they tell me it got better, that's a kind of an indirect sign that they're probably using their PAP machine. And the principle is very simple. You apply more negative pressure with an obstructed airway. And this is an arousal related to an acid reflux event. Now, many times we see arousals that we can't explain in people who aren't meeting the criteria. And that could be, in many times, reflux. And reflux is actually very disturbing. The majority, 60% of these events, actually are associated with arousal. So it's not a benign phenomenon. It's really a symptom to inquire from patients with sleep apnea. Does it get better when you treat with CPAP? And according to this study, yes, it does. Obviously, there's always one outlier who's going to shift the whole thing just to make it prettier. Okay? But everybody actually has decreased. So there is an improvement in reflux. Reflux is a common symptom that improves. It actually could be a clue to the presence of sleep disorder breathing. Another association, and that's really a big one, is type 2 diabetes. Somewhere between 60 to 80% of patients with type 2 diabetes have sleep disorder breathing. That's a massive number. So in this study, this was done at the University of Chicago, they took 60 patients, 46 of them had sleep disorder breathing. And look at their hemoglobin A1C. That's a beautiful dose-response curve, if I've ever seen one. Okay? Clearly, it is a very common in this condition. Now, this is the problem. This is a study that looked at a primary care setting. And so how often these patients are actually being evaluated. And if you look at mild or moderate to severe, the gray bars are moderate to severe. These are all the studies that have found a high prevalence of moderate to severe. Pretty much the majority are over 50%. And yet, this study here showed a very small number because they looked retrospectively at primary care clinics. And clearly, in many primary care clinics around the country, this is not being observed. This is not being noted. This association is not known. And that brings me to another point related to our research, is that We may have clinical trials that have showed something to be beneficial, but it takes somewhere around 20 years for that to get translated. So the implementation and the implementation research is critical. How do we get this finding to be translated into improved outcome and improved care for patients in the community? Kidney disease, chronic kidney disease. This is another study that looked at CKD and end-stage renal disease. You pretty much can figure it out now. Look at the percentage of patients with sleep apnea. So there is a very high percentage of sleep apnea, and it's no surprise. These patients, most of them are hypertensive, many are diabetic, many have poor cardiac functions. All of these are actually risk factors and factors that will worsen sleep apnea. So the typical patient with a metabolic syndrome that we see in clinic, that's a patient probably has sleep apnea. Sleep apnea should probably be added as an, I would call it an unindicted co-conspirator into the metabolic syndrome. It has to join that family, and in many times we know that it improves. Now, I don't know if you have an ACO here, but I'm sure everyone's hemoglobin A1C numbers are tracked very carefully. Well, maybe we will have better results with hemoglobin A1C if we treat the sleep apnea instead of just beating up on the patients. We can still do that too. So how do we diagnose the disease? Clinical features, questionnaires, laboratory, and now this new world of out-of-center sleep testing, or now the new name, home sleep apnea testing. Morphology. Jay Leno does not have sleep apnea. He leads with his chin, okay? Retronathia, it's actually a fairly common sign. You see it quite a bit. Young, skinny individuals who have retronathia. And we should not ignore the role of morphology in these things. It's probably a starting point in many patients. Now we have all kind of classifications, malapati, lateral narrowing. None of these things actually could tell me that somebody does not have sleep apnea. They're useful when I see them. They're actually very helpful to educate the patient about the likelihood, but I'm not going to see someone with an open airway and tell them, oh, you don't have sleep apnea, go home. We look at everything else, but these are part of the metrics. Now, one of the strongest one, and this is also from the Wisconsin Sleep Cohort study, is neck circumference. So anyone who has neck circumference of 17, among the gentlemen, 17 or higher, you have a 31% chance of having sleep apnea. So I have a business proposal to people for the sleep lab. Go to department stores, find all men's shirts, 17 or higher, put a referral card. Okay? That is 30% will have sleep disorder breathing. Now, because of the difference between men and women, women tend to have lower neck circumference for the same BMI. And you can see the trend. So neck circumference is one that I actually look at very carefully and incorporate in every patient. And if you think about it physiologically, that's tissue pressure outside the upper airway. So that's a very quick surrogate measure of tissue pressure. Consequences, hypoxia, arrhythmia, ischemia. Cognitive consequences, systemic hypertension. Actually, patients with systemic hypertension is really a major consequence. And actually, a lot of this work started here with Maylaw study 20-some years ago. Cardiovascular disease and mortality. So let's talk about the risk for hypertension. And this is also redrawn from Paul Pepart's study in the New England Journal of Medicine. Just look at the gray bar, which is adjusted for everything. Because many patients with hypertension are obese, they could be smokers, they could have other comorbid conditions. You clean up everything, and just look at this gray bar. The odds ratio is 3, even after you account for body habitus, alcohol, or cigarette use. The bottom line, the number I want you to remember is clinically significant sleep apnea doubles your risk of hypertension, at least. Doubles it. Okay? So a good part of that idiopathic essential hypertension could also be related to sleep apnea. Patients who have resistant hypertension, 3 medications or more, please think sleep apnea. This is part of the reason. And again, this is another example where we could achieve better results by actually treating sleep apnea than keep adding medications. Well, this is where the rubber hits the road, the ultimate. Does this condition add to our mortality? Does it shorten life? And for years, every time I talk about this, people will tell me, stop preaching to us, prove to me that it actually does something bad. And now we actually have 2 studies, now 1, that shows us this. The first one is also, and you think I'm a little partial to the Wisconsin Sleep Cohort study, the Wisconsin Sleep Cohort study, 18-year follow-up. And these are the graphs. This is on the left, this, untreat all of them, here after subtracting those who were actually treated. And they weren't treated because we wanted to treat them, because they were treated by their physician. And clearly, AHI over 30 had higher mortality, unequivocal. And that became even more prominent. So severe sleep disorder breathing, defined as AHI of 30 or higher, had a 3-fold increase in mortality over an 18-year period. All-cause mortality. That's actually an unequivocal, compelling number. It's always good to see other studies that are showing the same thing, done different place, different population. And this is the Steepheart Health study with 6,000 participants. Now, the difference between the 2 studies is, while the Wisconsin Sleep Cohort study was just Wisconsin, it reflects the local community. The Steepheart Health study had multiple cohorts throughout the United States. So it had more geographic, racial, ethnic, and socioeconomic diversity. So it has even a broader reach. And this is the same thing. Look at the red curve on the bottom. Okay? And this is a 10-year period. So the effect, we don't even need to wait 18 years. The effect is seen within a few years. You can see that these 2 curves start diverging somewhere by the 3rd or 4th year. So untreated sleep apnea, I can look my patients in the eye and say, untreated sleep apnea is going to shorten your life. And each and every one of you can do exactly the same thing. Now let's talk a little bit about treatment. We have, in our conversations about treating sleep apnea, we have stolen something from the hypertension world. The hypertension, they say blood pressure of 140 over 90, and we talk about it with some precision. But think about it in terms of methodology. Whether you live in Madison, Wisconsin, Vancouver, Beijing, or Bogota, blood pressure is measured exactly the same way. The units are exactly the same. The devices are the same. Every clinic in the world uses it exactly the same. And that is not the case with obstructive sleep apnea, because how we define an apnea or hypopnea here may not be how it's defined there. What sensor we use here may not be what sensor they use there. There are literalists and inclusivists, and you take one study from one lab, take it to another lab, and you get a different HI. And that is part of the problem. So our numbers don't have the same level of precision. But that's why I tend to focus more on the symptoms and what the presentation for my patients are. So our analogy with systemic hypertension could go only so far. It actually doesn't work beyond that point. And at some point, maybe we need a metric other than counting the number of events. We don't really know if that is truly the injurious signal. We have no idea. Maybe it is the episodic hypoxia. Maybe it's the sleep fragmentation. Maybe it's the increased intrathoracic pressure. Maybe it's a combination of both. And maybe it's different in different population or different individuals. So AHI is not an optimal metric. And our operational definitions vary. So if you are treating a Medicare patient, you are required to see 4% desaturation to count it as a hypopnea. But many other commercial insurance, you don't. You can use other definitions that have 3% or arousals, which leaves room for individual judgment. So that is one of the challenges that we face in this field. And again, our methods of measurement may also vary. Another problem why I've always been, and I want to inflict any more physiology after this one, is that Our method of measurement using the desaturation depends on host factor. So this is an obese individual, and this is a non-obese individual. Look at the functional residual capacity. And if you think of the FRC, it's how much air we have at end expiration. That is our oxygen store. So if this individual stopped breathing to the right, he or she has more oxygen stores than this one. So he or she is less likely to desaturate after a 10-second pause than this one. So the definitions that use desaturation to define an event have a bit of a problem because it's incorporating host factors that have nothing to do with the upper airway. This is courtesy of Sam Kuna, Philadelphia, and this is the very first nasal CPAP machine in Australia. It's an inverted vacuum cleaner with tape and truly a vacuum cleaner tubing, okay, a mask, and this is very simple. It's a simple principle. I call it inflating it higher. Your bicycle tire is flat, you inflate it, you pump air under pressure. And they tell me, why do I need a study? I tell them, well, everybody has a different PSI. We need to know what your PSI is. And actually, the old days sometimes were better than the new ones. They used to have individualized custom masks. And I see here, based with this guy with a mustache, that Mark Twain actually had sleep apnea. Does it really do any good? Well, there's a whole lot of evidence, and we can always argue it. But let's look at some simple metrics. This is reduction in motor vehicle accidents. And you clearly see that the number of accidents decreased after treatment with CPAP. There are 3 slides that are exactly the same, but does hypertension improve after treatment with CPAP? And these are a whole bunch of these, and this is a forest plot. You want to be on this side rather than on this side. And this is the average of the pool. And there is a small but highly significant from a statistical standpoint decrease in blood pressure. So when you're looking at population, you are seeing an improvement. And you see the same thing when you look at systolic blood pressure and the same thing when you look at MAP. So the net effect in most studies is that if you treat sleep apnea, blood pressure will improve. There are data from other aspects, including cardiovascular consequences. A few words about how much CPAP is enough, time-wise. And at the end of the day, there are patients who don't really have hypertension. You want to look at some metrics, and quality of life may be one of these that matter, patient-centered outcome. So these are 3 outcomes: FOSC, functional outcome of sleep quality; Epworth Sleepiness Scale, which is daytime sleepiness, subjective; and MSLT, which is the objective testing of sleepiness in the laboratory. Now, Medicare has a rule of 4 hours minimum use of 4 hours to keep the CPAP. And where did that come from? And actually, I have patients who take it off after 4 hours saying, we passed. Okay? And the question is, do you need more? And this is a beautiful study from Terry Weaver where she looked at all of these 3 indices and looked at the improvement after a certain number of hours. Granted, 4 hours there was an improvement. But notice that it continued after 4 hours. You need the whole night. You need 7 hours. And you can also see that not all of them followed the same curve. This one seemed to start plateauing, but this one continued to improve. So the more, the better. So I tell my patients, you need to use your CPAP, you need to use your PAP every time you're asleep, including when you nap. Every time you're using it, you sleep, you need to be using it. So clearly, 6 or 7 hours is what you need. And the other thing I've started adding in the past few years, and you need to sleep more than 7 hours of sleep. And you need to use the CPAP at all times. So now, I am going to give you a case, an illustrative case of sleep apnea. And see, maybe some people will guess this one. So WHT is a 45-year-old male who have severe daytime sleepiness. He slept during a thunderstorm. These are official reports, so I'm not making up anything. Okay? And during a meeting with his boss. Had a good idea. He fell asleep on speaking platforms, in cars, while dining out, church, theater, at a funeral. Okay? He fell asleep while playing cards, signing documents, and while eating. He became sleepy playing golf. Well, it's a boring game anyway, I understand. He could sleep standing up. Jerry didn't like that one. People saw a deterioration in his mind and expression. They said he was ripe for a stroke. Frequent errors. He was referred to as the blunderer. He lost his job. Okay? This may have saved his life. Free from the strains of his challenging job, he dropped his weight from 340 to 264 pounds. His sleepiness vanished. Blood pressure fell. In the last years of his life, he was extremely effective as President William Howard Taft. Okay? He was the first president to get stuck in the bathtub in the White House. They actually had to get a crane to pluck him out of there, and they had to build a bigger tub in the White House, courtesy of President Taft. He was the governor of the Philippines. You see him here asleep, and this is a close-up, okay? Secretary of War, President of the United States, and Chief Justice. When he lost weight, he was actually one of the most effective Chief Justices. And you can actually track his weight and his performance. Here, when he was governor of the Philippines, he gained weight. Then I guess the war made him lose a little bit weight. He gained weight as president. This is when he lost his job. He wasn't reelected. He dropped his weight, and this is when he was Chief Justice. So, obesity was present even then, okay? And blood pressure dropped when he decreased his weight, and who knows, his sleep apnea probably improved. So, in summary, I told you I'll tell you about a few things. Increased obesity prevalence mean we have higher prevalence of sleep apnea. It's no longer an incidental disease that for the high subspecialties. Okay? It is a primary care disease. It's a disease that any one of us who deals with patients need to treat. Think of comorbid conditions. Think of the interaction between sleep apnea and all of these conditions. Hypertension, obesity, diabetes, chronic kidney disease, reflux. Okay? All of these interact with the disease. Snoring and hypersomnia in clinical intake. Do you have in the review of system, I'm sure you have fancy review of systems in the EMR with everything listed. Do you have sleepiness? Do you have snoring? Do you have poor nocturnal sleep? The answer is no. Okay? I've reviewed a bunch of these. They have galactorrhea and enuresis for adults, pre-printed forms, but they don't have sleepiness. They don't have snoring. We need to move sleep into the center of this. It's 1/3 of human life affecting the other 2/3. It can't be just an incidental question on the way out. Future issues for us. I didn't talk about this, but unattended monitoring is here to stay. We cannot solve traffic problems by building more highways. We need more efficient systems. We cannot treat the obesity, the sleep apnea epidemic associated with our obesity epidemic by building sleep labs. We need to reach out to the population. This thing is here to stay, and we need to start incorporating it into how we treat patients. I didn't talk about different phenotypes. We talk about sleep apnea like it's one disease. Is asthma one disease? Is COPD one disease? Is hypertension one disease? There are probably multiple pathways that they manifest to us morphologically and to the patient symptomatically as snoring, apneas, and daytime sleepiness. But there are probably multiple pathways. And maybe the challenge before us is to start to design diagnostic and management approaches that focuses on these different phenotypes. Reimbursement changes are starting, and maybe we need to start thinking in terms of chronic disease management. The idea of piecemeal, encounter-based management is probably gone, and if it hasn't hit here, it hit in many other places. We need to start thinking in terms of population health, managing a large number, managing lives, and treating all the conditions associated with them. Adherence to therapy. One of the things that Jim Scatterwood used to tell me, that CPAP is not a pleasant treatment, and one day it'll be in the Smithsonian. And he's right, but we have nothing else. Okay? until we have other treatment, we have to stick with this and find ways to actually improve patients' adherence, patients' acceptance, because otherwise, if it's not being used, it's not really a good piece as a dust collector on a nightstand. So with that, I'll be tell you that actually sleep apnea is now a family disease. There's a husband and wife who have it, and I'll be happy to answer any questions.
Thank you very much, Dr. Badr. I'll ask you to call on the audience, but first may I just ask, I recently saw a patient with atrial fibrillation. Most of my patients have atrial fibrillation, who told me that while he didn't like his CPAP, he was getting an APAP, and I didn't know anything about APAP, but he said it's a better sort of CPAP. So I looked it up. I'm wondering if you could comment on that change in technology and the relationship you see with atrial arrhythmias.
Okay, great. That's all right. APAP is basically automatic. It's an intelligent CPAP. So instead of having a fixed CPAP level that we set, and we use this quite a bit now in patients who have garden variety sleep apnea. I have to be careful when a patient has central sleep apnea. We don't trust the algorithms in the AutoPAP many times with central apnea because they're based on is the airway open or the airway closed or is it narrowing. Now, AFib, and I probably should have mentioned something about it, sleep apnea is a huge issue in AFib. And if you don't treat their sleep apnea, your ablation may not work. And now there's strong evidence to that we have to treat them. Actually, probably 20% of my referrals now are from our electrophysiology colleagues who are sending all of their patients with AFib for evaluation. I think the evidence in this one is compelling and definitely shouldn't be ignored. Yes? The question is, how do we select people for home versus in-lab studies? For the most part, actually, we don't have much of a choice. Insurance companies are dictated. But I tell you who is a good candidate for home study. A patient who has what we would call garden variety sleep apnea without significant comorbid conditions. So an individual with, say, BMI of 37 who snores, just has hypertension. They don't have any condition that may degrade the quality or the interpretation of the recording. So, example, a patient with heart failure is not a candidate. Patients with COPD is not a candidate. Patient with Parkinson's is not a candidate. Some insurance companies will also allow us to do it on patients who have, to do home testing in patients who have BMI over 50 because the recording may be poor quality. We have a lot of them. And patients with renal failure or ventilatory failure such as obesity, hypoventilation. So the garden variety, home testing, anything else will probably be, which is about probably a third of the patients depending on where you are. Yes?
Could you comment a little bit on the perioperative morbidity and mortality with patients with OSA and whether it's treated OSA or untreated OSA?
The question is about the perioperative mortality. This is actually a huge issue, especially in the bariatric population, because this is where we see it. One of the things we're trying to do, and many places are starting to do, is to screen patients who are high risk before surgery. And that probably has to be like a couple of months if it's a scheduled surgery, and treat them with CPAP while in the hospital. Anything that's abdominal or thoracic surgery, the diaphragm is dysfunctional now. It's really not functioning well. And on top of it, they're taking opiate analgesia. So there's actually, they need to be monitored. I've been advocating that we test all of these patients before they're even scheduled. We have to be careful not to be too close to the surgery from a hospital standpoint because they don't get the reimbursement. It gets lumped under the surgery, which hospitals don't like. Yes? Sleep position is there a question, is there an effect of the sleep position, those who cannot sleep prone? The back is the worst. So supine sleep and we see it in mild cases where sleeping on the side is associated with improvement. It's not enough to be a therapeutic intervention, at least not in my mind. It may decrease the appearance of the condition, but I think it's still there. I would say it's marginal at best. That's my view. Oh.
Would you like to comment on the influence of age on prevalence of sleep?
The question is about the influence of age, and that's actually a great question, and this could take a whole hour in and of itself, but I'll be brief. There is an increase in the prevalence as we age till somewhere around 60, and then things start to diverge, and then it picks up again. We don't really know if that's the same condition or not, and I just came back from a whole symposium on sleep and aging, and that was the question. We don't really know what the threshold of events for an 85-year-old who's otherwise healthy. But one other thing we know about the aging effect is the gender difference narrows after menopause. So among the 65-year-olds, the gender difference is much smaller. So more women have it. They're close to the number of men. The decision that we don't know is in terms of treatment, which is probably what your question is. That is probably has to be individualized. So we don't really know, is some number of events, 5 or 6 or 10 in an 80-year-old pathologic or not? I don't have an answer for this one. Yes, Jerry.
Thank you. 2 clinical trials with heart failure patients using different forms of positive pressure treatment have failed. One very recently. Is this of concern, the use of this treatment for people with borderline cardiovascular problems and cardiac problems? And where do you see the future of this treatment going?
The question is, there are 2 clinical trials, one in 2005, the CANPAP, that showed no effect of CPAP, and a recent study with the adaptive servo-ventilation in central apnea and heart failure that showed higher mortality in the treated group. And the common thing between these 2 is actually the presence of positive pressure. The answer is that I don't know. I think because all of these studies took all comers, and they did not distinguish, and this may be where we need to be going in the future. Even the heart failure population, there may be more than one group of heart failure and reduced ejection fraction. And maybe those who have low volume state shouldn't be on positive pressure, and those who have high volume state would benefit from positive pressure. So I would argue that the 2 studies lumped more than they needed to lump, but I can't really answer it. Although I am personally a fan of CPAP, good old-fashioned CPAP, and I would like to see where it fits perfectly.
We're going to have to close there. I want to thank Dr. Dempsey and Dr. Jarjour for arranging Dr. Badr's talk. Thank you. That was really great.
Thank you.
So nice to meet you.
Thank you.